Hello, welcome to this presentation by FERNE, the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled The Evaluation of Emergency Department Dizziness Patients, New Concepts. My name is Edward Sloan. I am currently Medical Director of the Physician Assistant Studies Program at Dominican University. I have most recently been an attending physician at Carle Foundation Hospital, and I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. Support for the development of this lecture was provided by EB Medicine. I am currently President and Board Chair of FERNE. The content for this lecture comes in large part by the monograph titled The Timing and Triggers Approach to the Patient with Acute Dizziness by Jonathan Edlow. It was published in Emergency Medicine Practice by EB Medicine, December 2019. Other parts of this educational lecture and the complete lecture are available at the fern.org website or on our YouTube fern.org channel. Also available is the June 2020 podcast, which was presented to participants in 46 countries, as well as a CME option on the EB Medicine website at ebmedicine.net, as well as at the specific website address noted below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Now, remember benign paroxysmal positional vertigo? We talked about this. When considering BPPV, there are two causes, posterior canal and what is also called the other being lateral canal, which is less common, which is movement of the otoliths in a position in the canals, which is abnormal. So BPPV, posterior canal problems in 80 to 85% of cases. Our Dix-Hallpike maneuver is diagnostic. Upbeating and torsional nystagmus can be seen. The Epley maneuver is the treatment or therapeutic maneuver that treats this type of dizziness. It repositions otoliths which have moved into a not normal location. So again, what's the pathology of BPPV? These are dislodged otoliths from the utricle which migrate into one of the semicircular canals, and they don't belong there. And then they begin to stimulate the semicircular canals in a way that's pathological. The posterior canal is the most dependent, so it's the most commonly problematic canal because the otoliths will fall into this dependent posterior canal. The otoliths cause motion to be simulated. And you can also get what is called the heavy cupula, which simulates motion as the otoliths become stuck in the cupula. And what this basically does is it disrupts the normal vestibular ocular reflex, VOR, which maintains normal gaze with movement of the head. So the Dix-Hallpike test. Now this is a complex test, and I recommend you go to YouTube and look at videos of how this is performed. But you basically put the patient on the table, outstretched legs, head is turned 45 degrees to one side, then it's dropped 30 degrees below the table, and you examine nystagmus for 30 seconds. If the maneuver causes symptoms with nystagmus, when you drop their head 30 degrees below the table, 45 degree tilt, you know that it's likely BPPV because of this positive Dix-Hallpike test. Lay them flat, 45 degree, drop down on one side, do it again, 45 degrees, drop 30 degrees below the table. If on either side there are profound symptoms and nystagmus, this is a positive Dix-Hallpike, in which case the Epley maneuver may be done to help reposition the semicircular canal crystals, which don't belong there. So, head turn and drop down, assess for symptoms and of vertigo, dizziness with the Dix-Hallpike, examine for nystagmus. If both are positive over 30 seconds, the test confirms the BPPV diagnosis. Now, With the Epley maneuver, you're turning the head in all three planes. Why? Because there are three semicircular canals in three planes. The changing of the head position will allow for the otoliths to return to their normal location away from the semicircular canals. The cure may require repeated Epley maneuver sessions, much like physical therapy. And in fact, there are ENT specialists that perform this maneuver on a regular basis in vertigo patients. And I believe that in the emergency department, although you can do the Epley maneuver, the fact that it doesn't help in the presence of a positive Dix-Hallpike test and the likelihood of positive BPPV, the fact that the Epley maneuver doesn't work doesn't mean it can't work, and you should refer these patients because it may require multiple episodes of the Epley maneuver like physical therapy in order to move the otoliths completely and resolve this BPPV dizziness. Now the next two slides talk about how you do the Epley maneuver. We don't have time in this presentation to go through it in detail, but what you're trying to do is you put the patient flat again, turn their head 45 degrees away from the midline, and then you turn it 90 degrees to the contralateral side, and you hold it in these positions for 30 seconds. And then you ask the patient to roll onto their shoulder while their head is turned so that you can move these otoliths. And again, you do this in a way that you're attempting to move the otoliths to a normal position. And I've actually given a reference here so that you could look more at how you do the Epley maneuver. And I suggest looking at videos on YouTube to help enhance your understanding of performing the Epley maneuver. So another question regarding BPPV diagnostics. In a patient with possible BPPV, the most likely physical exam maneuver to help confirm the diagnosis is, of course, D, the Dix-Hallpike maneuver. And that's explained on page 14 of the monograph. In conclusion, the ATTEST system for the evaluation of the dizzy patient includes the following. A, associated symptoms. T, timing and triggers. ES, examination signs. And T, confirmatory testing. ATTEST. When evaluating an ED patient with dizziness, please consider the following. Using the ATTEST system for evaluating ED dizzy patients, those patients with acute, severe, continuous symptoms should be considered to have acute vestibular syndrome. Patients who have intermittent symptoms or non-continuous symptoms at the time of evaluation are noted to either have triggered or spontaneous episodes of dizziness and vertigo. Topping the list of diagnoses using the ATTEST system are orthostasis, BPPV, or benign paroxysmal positional vertigo, and posterior stroke. BPPV can be diagnosed with the Dix-Hallpike maneuver and can be treated with the Epley maneuver either in the emergency department or in follow-up. It is noted that you should evaluate patients with caution in the setting of the COVID-19 pandemic, as the COVID virus can cause neurological symptoms and or can complicate those neurological symptoms because of poor PO intake and dehydration, which can cause orthostasis. Electronic medical record templates and dot phrases can help to make the exam process more systematic and easily accomplished using the ATTEST system. When evaluating dizziness patients in the emergency department, the following is recommended. Understand that the dizziness pathologies using the ATTEST system fall into 3 diagnostic strata and basically involve 6 diagnoses and 3 specific treatments for those diagnoses. Also recommended is that you study the Nystagmus findings, significance, and BPPV maneuvers, Hallpike and Epley, online and in the monograph from which this lecture was obtained. Also, create EMR templates and dot phrases to exclude posterior stroke findings in your dizzy patients in the emergency department. Explain the etiology of the dizziness, including the diagnosis and treatment, and provide appropriate referral for patients with dizziness, explaining to them symptoms which should cause them to come back to the emergency department for repeat evaluation. Lastly, Utilize caution when evaluating dizziness patients in the emergency department in the setting of COVID-19, as this virus has both neurological complications and symptoms and can cause orthostasis due to decreased PO intake. If you have specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you to go to the fern.org website for more content related to this educational program and other content related to the care of patients who present to the emergency department with acute illness and injury related to neurological emergencies. Thank you for your participation in this FERNE educational program.